I'd like to thank everyone for coming this morning, and for those of you who are watching on live stream today. I could think of no more important topic on September 27th than thinking about where do we go from here. So we have Hopkins began this healthcare leadership series. It's our idea is to bring people from different disciplines and industries together to talk about key issues in healthcare. This is our second in the series. The first one was about precision medicine. And today we're going to talk about precision medicine, but in the context of better health and lower costs and high-value care. And as I said, I think most of us woke up this morning and said, okay, what are we going to do now? Because clearly we have a lot of important issues that we need to address in terms of healthcare in the United States. The issues did not go away yesterday. We still have a healthcare system that's spending between 17 and 18% of GDP. And the trajectory, given the demographics of this country, are nowhere but increasing that number. And when you think about it, there's not demonstrable better healthcare results from that large expenditure that this country spends on our healthcare. And that you could look at infant mortality rates or life expectancy, and you think that we have a long way to go in terms of improving the health of this country. Given that dynamic, I think we brought together some experts today to think about how we're going to address this long-term issue of really a healthcare system that spends more than this country can afford in the long term, and how we're going to balance trying to reduce these costs with our thirst to improve the health of the country at the same time, thus improving the quality of the healthcare we provide. And I can think of no better panel than the four people we have here to help answer that question for us. And I'm going to introduce our speakers first. And I'll start at the far end. Dr. Pina Pronovost, who's the Senior VP for Patient Safety and Quality and the Director of the Armstrong Institute for Patient Safety at Johns Hopkins Medicine, and I think is recognized as one of the drivers of quality, safety, and better healthcare in this country. Then we have Michael Cantor, who's the Executive Vice President and Chief Quality Officer for the Permanente Foundation, who oversees their quality programs. And I think we could all think that Kaiser and Kaiser Permanente are really people that we look to in leadership in terms of what they can provide in value to their patients. And then Lisa Simpson, who's the President and CEO of the Academy Health, which is a professional society for health service researchers and health policy analysts. And Kurt Medeiros, who's the President of Optum Life Sciences at United Healthcare, who is really, I think, one of the organizations that's really pushing the boundaries of the use of data and analytics in tackling some of these big problems. So I think first I'd like to ask each of them to give us just 5 minutes or so about how they're thinking about how we're going to bring value to our patients here. So, Peter, why don't you begin?
Was on. Thank you, Dean Rothman. Rusty Schweickart was one of the first astronauts to circumnavigate the globe from outer space. And when he landed, was asked, what does the Earth look like from outer space? And at the time, there was turmoil in the Middle East like today, and he said, what I noticed is there's no lines from outer space. We invent them. Yet, on Earth, we kill each other over those lines. And if I think about what we're going to need to do to drive value, is we're going to have to erase those lines that are dividing us, because each of us are going to have to work aligned to solve the problem. Some examples. Regulators right now serve a vital role, but many regulations drive up cost. We, for example, spend $500 million a year on preoperative testing for cataract surgery when a randomized trial says it adds no value. We require patients to be homebound to get IV antibiotics, and if they're not homebound, we admit them to a nursing home rather than saying, no, they can still walk and get them at home. We require that nurses do a human double check of medications when there's an electronic double check that we can do would save 20% of labor productivity. The pay for value is another area that we have to drive, and that's critically important. But right now at Johns Hopkins, we're responsible for 1,200 different measures in all our different product lines. Think about trying to manage that complexity. There's no standards for how accurate these measures need to be. And some of the measures for bundled payments are wise, but they're too narrow. For example, they start when somebody needs a procedure, but we know 30% of procedures are unnecessary if you do the right diagnosis. And they end their measurement at 90 days, where if you have a better procedure, your functional outcomes at a year or 5 years are much better, and that's what patients ultimately care about. We as providers have a big role to do this. We accept harm as inevitable rather than preventable. We haven't had disciplined accountability and management systems, and under Dean Rothman's leadership, we're putting those in, and we haven't embraced systems engineering and systems design in healthcare. Perhaps most importantly, though, is you, or all of us as people, have the biggest driver of our health. Somewhere between 40 to 50% of our health outcomes are determined by our behaviors, and we could do much more of supporting healthy behaviors to keep us well. Thank you.
Let me just make a few comments. I'm Michael Cantor from Kaiser Permanente, and I'm on the Permanente side, which is the medical group side of the delivery system. And I emphasize that because I think one of the things that can help drive value-driven healthcare is really the concept of integrated delivery systems. And I think the accountable care organizations is a step in that direction. But having the insurance company and the hospitals and the physicians all in the same boat, rowing in the same direction, is hugely powerful. And that's not to say there's not often disagreements, but the alignment, I think, greatly helps remove waste from the system. Right now, we care for about 3% of the U.S. population. If you look at folks who are in the Medicare 5-star plans, 81% of those people are Kaiser Permanente members. So the quality can get moved in the system I talk about. The key is an independent medical group. I don't think we want to go to a system where medical decisions are removed from physicians, yet physicians need some accountability and some group infrastructure, so the multi-specialty medical group, I think, is key, and having the proper governance and the proper culture, and I think Peter alluded to this issue of accountability for delivering safe and effective care has not been present in most medical groups. I did want to emphasize patients need to be part of that team. I think that's actually a fundamental flaw with how we're trying to do medical care. When you look at the IOM 6 aims, it talks about patient-centered, and we like to modify that and call it person-centric, because most of the time patients are people. They only visit the healthcare system a small amount of time. What they do in the 99% of the time they're not in our offices is a huge determinant of health outcomes, from smoking cessation to weight loss to getting flu shots, which I hope everyone in this room has gotten or is about to get. These are key drivers of health outcomes, and I think partnering with the patients to do that is a huge benefit, and providing patients the self-management tools is another key driver of value. Last point I'll make is medical education, I think, needs to be redesigned. We are opening up a Kaiser Permanente School of Medicine 2019 or 20, and I think we need to start teaching different values and different ways of approaching it, particularly with a systems engineering point of view to teach quality science and quality improvement.
Lisa.
Sure. Thank you, Dean Rothman. And I want to make 3 quick points, and we'll get into probably aspects of those as we have our discussion. So the 3 points are research, precision, and patience. So some of the points you've already heard my colleagues speak, and you'll hear from my colleague to the left. We know what we know about what is high-value care because of research, because of the studies and the work that has been done, funded by, notably, the federal government in its various agencies, the Agency for Healthcare Research and Quality, NIH, the Patient-Centered Outcomes Research Institute, and the VA. And when you think of research, it's really important to remember a quick way I like to think about it is there's 3 Ds. There's discovery, development, and delivery. And if we don't focus on doing all 3 well, we're not going to achieve high-value care. So while we need the discoveries, like what causes a bloodstream infection and understanding the biological mechanisms, we also need studies like Dr. Pronovost, my colleague, led, where he developed the intervention to reduce bloodstream infections. Until we develop those for all the issues that we're confronted as providers and patients, and I'm a pediatrician by training, we're not going to have enough answers. But even then, with discovery and development, we've got to have delivery. We've got to actually figure out how do we get the right care to each patient in the right circumstance, in the right setting. And that's when we will get to high-value care. The second point is on precision. So we often think of precision medicine as genomics and the incredible discoveries we're making and how we can target specific treatments based on a patient's biological characteristics. But precision also means making sure that patients don't get what is not right for them. And so when you think about high-value care, you also want to think about low-value care. And you've already heard Michael and Peter also mention instances of eliminating, and there's some examples in your packet here as well, of first identifying what is the right service for the right patient and then eliminating those that don't work. So the question is, well, what works in eliminating low-value care? And we actually commissioned a paper written by Carrie Colos, a researcher at Dartmouth Hitchcock. But for those of you who are staffers, she's actually a Robert Wood Johnson Fellow, Policy Fellow this year, and will be working here in Washington. And she reviewed what we know about effective interventions. And so I can speak more about that later. But we are learning, again through research, which interventions actually work to reduce low-value care and make the care more precise for every patient. So to end on patients, we've all mentioned it. I think we're going to keep coming back to this central role of patients in high-value care. So what do patients think is high-value care? We recently conducted a project funded by PCORI on that very question. How would we actually develop measures, not to add to the 1,200 you're accountable for already, but hopefully better, get rid of the measures maybe the measures aren't high value and focus on measures that really push the systems towards better outcomes and meeting patients' needs. And when you talk to patients about what is low value care to them, yes, they want to make sure they have safe care and the right care for them, but they also bring in the dimensions of poorly coordinated care. The tests aren't transferred from provider A to B, and therefore they're repeated. And so poor value, low value for them is when their time is wasted. They have to take time off work. There are real costs to them, both financial and opportunity costs from low value care. So I think we have to keep that in mind as we think about what is high value and what do patients value. Thank you.
Kurt?
Is this on? Yep.
Yeah.
All right. Well, first I would say I'm humbled to be part of this panel. I think there's just a tremendous amount of ideas here. And I think as at Optum, we look at high-value care as a very simple idea that's very, very difficult to achieve. And I think some of the themes that my colleagues mentioned around the right treatment for the right patient at the right time. We also like to add a couple other things. What's the right setting, as well as what's the right cost? And continually looking at opportunities across that entire continuum to optimize is one of the biggest challenges we have, because really the right care, as you're saying, ultimately is defined by that individual. And we have to have that dialogue between that patient as well as their physician to define what are the right treatment options based on their current state of disease and what their likely progression is. There's challenges along the entire continuum. As we said, as new innovations keep getting added into the marketplace, to be able to manage what is the right treatment for the right patient. If I'm a prescribing physician, it's information overload. And then often the performance of those treatments in the clinical studies versus the real world are different. And so how do we take real world data and apply it back into those treatment decisions to understand not just how can genetic information add to that equation, but other comorbidities, other profiles. When it comes to the right setting and the right cost, there's a couple key things that we need to really step on the gas. One is in sort of value-based care, and this was mentioned earlier by Peter. There's a lot of new innovations coming to the market. I'm very happy to see some manufacturers really taking seriously the opportunity to put their money where their mouth is in terms of reducing the expense or limiting the expense if the treatment doesn't work for that particular patient. But then there's a whole nother side to that, which is how do we administer that across a large population and have the data to show what patients got, how did they progress, and have a constant set of measures, right, that allow us to keep track of that. The last part is really the right setting. And so we've continually been investing in how do we actually find the optimal care setting. It was mentioned earlier around, the need to go into an inpatient setting to get antibiotics. Part of what we're continuing to do is driving care to the right setting for the patient. Sometimes that's going to an infusion center. Sometimes that's actually delivering care in the home. And so in 2016, and it's increasing in 2017, Optum has invested significantly to do over 1.5 million home care visits to actually meet the patient where they live. And so continue to push on these different levers is something that we all have to continually strive for.
Great, thank you. I actually would like to make this session a little provocative today because I think it's a time that I think we're all looking for answers. So I'm going to start off with my first questions, and then, so I think you all, talked about a variety. First of all, it was all tremendous, and I think you all touched on, I think, which are some of the fundamental issues, which is how we're driving this value proposition. And what I think is somewhat lost in the discussions that you hear in the media is the fact that everyone within healthcare is trying to really drive value.
Right.
I mean, everyone complains about the cost, but in fact, we know because we're all inside this industry about how everyone is really trying to drive this issue. And so we have staffers here, so so we have the opportunity for people who are going to be involved in framing how healthcare is changing. I'm going to ask a couple, two quick questions, and I'm going to open it up. The first one is, so value is this equation of quality versus cost. And for those of us who have been in this industry for 30 years, this is not a new issue. And 30 years ago, we began with cost, to be quite frank, as a driver in the 1990s. And then we saw what would happen if cost was the only driver of change. And so we added quality in this value proposition, because you can get your costs down, but then sometimes quality is going to suffer. And I think we're having that argument again when the people who are really paying for this system, and that could be big employers and that could be the government, is again dealing with, you got large employers, corporations, they can't afford changes in healthcare. And I think a lot of the drivers to what we've been talking about in terms of the repeal of the ACA is not only the corporations can't pay for it, but private people can't pay for the increased insurance costs that have come along over the past several years. So you're going to have this real driver for cost, but you also have a real quality issue, and we have a lot of interference. So when you think about it, and you have these congressional staffers and the Congress thinking about this, what would be your advice to them? Is the real issue, should they be focusing on the cost issue, or should they be focusing on, okay, we'll afford 17% of GDP if we could really demonstrate that quality was getting better? Because I think it's a fundamental question that I think people need to understand, and it's just been on the cost side, it's all we've been hearing. So do you think that if in your systems, are you focusing on cost or are you focusing on quality? And I know you're going to say both. But if you had to think, what is it driving? Is the driver really going to be cost over the next 10 years?
And before my colleagues jump in, I would just say that I think we've got to think of another piece to add to the value equation, which is cost, quality, and access. because as costs are being shifted to individual patients and families, then there is care being deferred. So it's even harder, the old adage, quality, cost, access, pick two, because you can't get all three. So I just throw that in to hear what you're all doing on all of this.
I mean, I'll start, and the answer to your question is both. And I think it has to be when we look at quality, actually, and using the 6 aims of IOM, which include safe, effective, efficient, equitable, patient-centered, and timely. 2 of those, which are efficient and effective, directly relate to cost. So to separate cost and quality is a little bit artificial. I'll give an example. We started many years ago on a large campaign to screen for colon cancer. And we did that because the randomized trials said this is a good thing to do. As it turns out, now that our screening rates are quite high, we've seen a massive shift of stage to earlier detection. Our survival rates are up, but in terms of the cost of chemo for colon cancer went really high. It's $250,000 a patient. So investments we made 5 or 10 years ago that cost us real money in our bottom line are 5 to 10 years later now saving us. So I think there's a time dimension in this cost-quality issue that we also need to decide, are we looking at a 1-year horizon or a 20-year horizon? And I think we need to take the latter, and when you look at it that way, some of the cost-quality supposed trade-offs, I think, start to get greatly mitigated.
Yeah, and Dean Rothman, I would add that our job in the delivery system is to create maximal value because we discover new interventions. Who would have thought Hep C is a curable disease, right? Or many of these cancers? So we don't want to and there's a price tag with it. What I think we need to do is drive out the waste, and then what percent of GDP we're spending on healthcare is really a policy decision. Would we rather invest in preschool or other social goods? Our job, and there's a lot of it right now, is to get rid of that waste and to continually to innovate and discover and optimize patients' health and outcomes. But for the people on the Hill, a couple lessons to keep in mind is that we've learned that payment policy is a very potent pill for the quantity of care patients buy, but it is a really weak tonic for the quality of care they buy. That is, consumers are really price sensitive. So when you change their copay, they buy less, but they buy needed and non-needed care at the same rate. It's not differential. It's a hammer when they need a scalpel. And that the quality of care is much more driven by intrinsic motivation, by professional organizations, by research, by the delivery system, by the private sector innovating to drive that. And we have to make sure that's supportive. Now, a final piece, Dr. Rothman, that is key is when you look at how to control costs in any industry, there's only really 2 mechanisms. You have to use fewer services or you grow productivity. And in healthcare, the only policy debate is using fewer services. And we're the only industry that does that. Every other industry solved their cost problem by growing productivity. And healthcare has negative productivity. Most hospitals have gone 4x in the number of FTEs they have over the last 20 years. I mean, there's no other industry that has anywhere close to that trend. And a big part of it is the lack of systems engineering that Michael said, is that we buy devices that don't talk to each other, that you can't share data, and that are clunky and clumsy for our clinicians. So almost every technology we've put in, matter of fact, I don't know of any that hasn't, hurts our labor productivity of our doctors and nurses, and that needs to change.
Please.
2 additional comments. One is when we talk about quality in this equation, I think we've over the last 20 years focused on the more process dimensions of quality. If you get to your 6, we've
Right.
sort of translated that into this, what I like to call sort of, measurement industrial complex of, lots of measures, but not getting to ultimate outcomes. And so we're falling short in our ability to actually, measure, identify, and reward real quality that leads to patient outcomes. And I think there, the payment system, I loved your potent pill, weak tonic analogy. As we see payment innovation really trying to move towards outcomes, that frees up the health system to innovate, to try new things, and really get to that dimension. The second point I wanted to make is the issue of scaling. Research and individual providers and health systems have been incredible at innovating solutions that are effective. But where we fall short as a country is then taking that and replicating it, adapting as necessary for different contexts, and really getting to scale for improvement. So, we know, Peter's Keystone, you've done actually one of the more amazing jobs with replication, thanks to support from the Agency for Healthcare Research and Quality and partnership with hospitals around the country. But that's sort of an exception. And how do we really take individual solutions when we identify them and really get them to scale so that we can get the most benefit and get those costs down?
Peter, you raised an interesting point. I'm going to, again, be provocative. So when you think about how to control costs and improve the health of the population, what is the role of the consumer? And so one could argue that a lot, as I think Michael talked about, a lot of what defines health for people are not occurring within the delivery system. It's going to occur if they stop smoking, they don't control their weight. So clearly, people or the consumer needs to have a role in improving health. Yet, as Peter, as you said, often consumers don't have all the information they need, and also the economic drivers can be such to disincentivize them to use the system properly. So how do you balance that role of the consumer in defining healthcare versus what is the role of the delivery systems and insurers? And Kurt, I'm going to look to you first, because you obviously must think about this a lot at Optum. How do you effectively use incentives for the consumer to improve their health, yet still have them utilize the system properly for the...
So absolutely, it's a challenge, and I think I'll go through a couple examples, and none of them have gotten all the way to the end of the equation yet, but we're really happy with the progress. One is sort of innovation in both self-care as well as in preventative care, and we're trying a whole slew of different things around engagement in weight loss programs, smoking cessation, to again try to meet the patient and really personalize it to their life and their situation, and try to build this into the benefits that their sponsor, their plan sponsor, is providing. So this is the standard, it's not the exception. And we're seeing a big uptick in investment in these preventative type of things. And even in the high deductible plans, preventive services and access to things like weight loss programs are really becoming the standard over time. So that's one aspect. The other aspect goes back to this alignment of payment incentives and overall quality. And so we've done some innovation projects in episodic-based care and oncology. And what we've seen there is we've actually opened up access, but we've actually defined standards, working with the oncology groups to understand, given their experience, given the data, what are the best treatments given different situations. And it was a surprising result, because what we saw was that we had a fixed payment to the oncologist, regardless of what treatment they chose. But the overall cost of care went down by over 30%. And so there are ways to align these incentives, like we were talking about with the Kaiser system, where we can get the physician, improve access and treatment choice, but actually drive down the overall total cost of care. And as that's progressing, to get back to the consumer point, from what we've learned, now what we're doing is we're infusing data around outcomes and total cost of care, not just the pharmacy component, not just the medical component, back to the physician so that they, at the choice point of treatment, they can sit there and speak with the patient around, how is this going to fit into your life? There are trade-offs associated with side effects and cost and treatment regimens in terms of length and others. And so providing that information at the point of decision and helping that conversation. We're now, next year, going to go as far as to pilot a consumer-facing tool in the oncology space that actually provides this directly to the patients. And so it's these types of innovations that we're continuously working on. The story is not over because this is really hard, but I do believe that there are opportunities if we're willing to innovate and invest in that engagement to really move the needle significantly, especially in high-cost areas.
It's not working. There we go. A couple of added thoughts. I think you're spot on. The patient is part of the team, or the member, or whatever unit you want to use. It's fascinating to me that you can take your automobile and look up what preventive maintenance you need and when you need it, but people can't do that so easily. We actually put in a system, our online personal action plan, where all of our members can actually go online and see what they need and when they need it. And it's been hugely successful, and the beauty of it is that it costs us essentially nothing. Once you build it, patients can actually take care of their own care gaps to a large degree. We just had a new tool we put on where somebody's notified when they need colon cancer screening. They click a button, and a kit gets mailed to their house to test their stool for blood, which is one of our screening methodologies. Very large uptake on that, very low cost. So I think part of it is an educated, informed patient. Opening up our medical records to the patient, I think, is key. Traditionally, they've been shrouded in secrecy, where physicians closely guard it and are dependent on, then patients are dependent on seeing their doctor to know what to do. I think we need more transparency with respect to that. Second thing is shared decision making. It gets to your issue of providing less services. There's a set of tools and principles where a patient and a physician jointly educate each other and then make a decision as to what's the appropriate treatment. And I say jointly educate each other because the doctor doesn't know the patient's goals of treatment and preferences, and the patient doesn't know all of the technical aspects of risk benefits. By sharing the decision, you actually can make a better decision, which I think ultimately contributes to value, and to me is a great way to deal with some of these high-cost, high-toxic treatments that are getting more and more prevalent as medical science advances.
Dean Rothman, I'd add that much of what this entails, or we're discussing, is behavior change, and it falls into this field of implementation or improvement science. It's grossly underinvested by federal government. It's about 2% of our research dollars are in the applied space. But all of what we're talking about is either changing provider behavior to do something or patient behaviors. And there's a mature science. It's generally not in medical schools. It's social science, it's behavioral economics, it's systems engineering that package together to drive these kind of change. And there are examples. The NHS has a very mature, well-funded implementation science team that draws upon those disciplines. Switzerland has really sophisticated incentives where patients declare personal health goals. And if they meet those goals, they get a very meaningful, somewhere in the 15 to 25% rebate on their health insurance premiums if their hemoglobin A1C is down or their weight is down. And I don't think we've been innovative with experimenting on the behavior side to drive health and wellness.
And a couple of points I was going to make, you guys touched on, so that's fantastic. So what I want to emphasize is we focus on whether it's the provider or the patient within the context of an overall community, is recognizing, again, understanding that one size does not fit all in that implementation strategy. So part of implementation science is understanding the context, where that care is being delivered or that intervention or what that patient is living. And that's where issues around social determinants of health really become very important as we try to get patients more, they're living their lives every single day. They only come to see us once a year if they're lucky. Always try to avoid the doctor, right? Stay healthy. And I think that, the movements that we've been working on, the data, Open Notes is this fabulous initiative funded by multiple funders. It actually received the Health Data Liberator Award last year from us at the Data Palooza. So getting patients really understanding their care and engaged in it is great, but again, that may not work as well in some communities, in some populations. Health literacy, limited English proficiency, lots of other factors play into this. So it just, again, speaks to what we need to learn about how to adapt those interventions to different populations. And then I think we've talked a lot about the issue of patient engagement in relation to preventive services and screenings. But if we look at where the big costs, again, it's end of life and high cost, high need patients, the very complex comorbid patients. And I think some of the studies that Peter alluded to in terms of behavioral economics, et cetera, hovering the combination of data innovation, apps, technology, telehealth, all of these are also going to help us, I think, deliver the right care to those high cost, high needs patients in a much more efficient manner.
I'd just like to add one thing. I think, I love the conversation. One of the pieces that's missing and we're starting to experiment with is that sort of longitudinal view, because there always is this challenge where a consumer, and this happens to me as well, is, well, that's not my problem right now.
Right.
And it's not my problem in my health, and it's not my problem in my wallet right now. So the next best action type of concept works very well for a segment of the population, but it's challenging when you look broadly, especially with chronic disease. And so some of what we're experimenting with is a concept that, we adopted from a large financial institution that you all may know that is promoting their green line to retirement. And so we're working on the concept, leveraging data and sort of care pathways based on an individual, providing them the context of how they compare to populations like themselves, but showing them the green line, both in terms of their likely pathway in health, as well as financially. And we're early in this, but we hope that there will help to drive behavior change with some of those people that are putting things off.
Great. So I'm going to open it up to questions in the audience or online. And if not, I'm going to ask the next one because I have tons of them. We talked, Peter, you mentioned the lack of return on investment on technology. And many of us who've been, because of meaningful use, invested a lot of money in the electronic medical record. And you each have given some examples of how technology can be leveraged. Do you think that, in fact, we're going to get a return on investment on these large investments we've had? And how long is it going to take? And where's the biggest bang for the buck going to come from? Of all, because I don't know, I get 50 emails a day from a technology firm wants to meet with me because they have a technology that's going to save Johns Hopkins millions of dollars. So where's the biggest bang for the buck going to come from in terms of investments in technology? Mike, I'm going to start with you because Kaiser's had an EMR for a long time, and I know they've been able to leverage that for return. So when you look at Kaiser Permanente's investments in technology, where was the biggest bang for the buck in the past? And as you look forward, where is the bang for the buck in technology going to come from?
So I would agree that technology is a dual-edged sword, and I think we're either going to spend a ton of money and get little value and make our cost-value proposition worse, or we're going to make it better. And I think the key is really sticking to principles of evidence-based medicine and carefully studying things as they get implemented and not going off too far into the latest and greatest, running up costs and not getting value. We need to be very careful about that. The EMR has been a particular challenge. I think the potential is huge, and my own opinion is looking out 20 or 30 years, I think we will get our monies back. Short term, I think it's cost a lot. It's created a huge source of professional dissatisfaction with physicians who generally don't like it. It's decreased their productivity in terms of measuring encounters per day. and how many patients they can see. I think there are some huge quality advantages in being able to measure and provide feedback on performance. I think that for a prepaid capitated system where you're not charging fee for service, some of the downsides of the EMR are mitigated because you're not collecting a fee for service and counter-based fees. Some of the tools I talked about being online and getting patient engagements will pay off. So I'm not totally sure I'm answering your question. I'm more also looking forward with the genomics and the big data that one could buy and analyze. And there's a ton of investments with personal devices and gizmos and gadgets. Each one needs to be evaluated under reasonably rigorous circumstances, in my view.
And Dean Rothman, I may add, you're spot on. The enormous investments we made in the EMR, the empiric literature would say there is no signal that cost or quality went down for. And it's hard to think of any other industry would make those kinds of investments without that signal. And so the question is why? Well, we need it to be digitized, and some of the federal incentives for money accelerated that, but the tools weren't ready for prime time. Their usability is horrific. I mean, putting a tool in that takes clinicians 2 hours at night to document on, no other industry would buy products like that. They would demand that they get better, and there's really little interoperability because the value of the EMR is not in putting data in. That's a commodity. It's in analyzing and using it to learn and improve, and it's quite challenging to do that. And the EMR data is a relatively small component and decreasing component of the total information we need around patients. I mean, if they're in the hospital for one day, we need the IoT, the wearables that you look at to see your heart rate and your mood and all what you eat and all these other health behaviors that drive your health that needs to inform how we do, and those aren't in the EMR. And there's this tension to say, is the EMR going to be the owner of the analytics and all that data? And my strong belief is no, they're not up to the tasks. It will be a platform like Dr. Rothman we're doing at Hopkins with inHealth that sits on top of the EMR that could ingest any type of data that we have that makes it easy to do analytics and do decision support tools and feedback. And I think that's where the value will drive from. The other piece that my applied physics engineers, it's a part of Hopkins that helped do the Pluto mission, laugh at us, is when they design a weapon system, when they put the Pluto system, they start with design requirements. In other words, what is it that this thing is trying to do? Write specifications, and then the technology supports that. We've looked, nobody has done that yet in healthcare. Like literally, there's no design requirements for a hospital, for a clinic, for what the system in general is doing, and I think that is what needs to drive the technology, and that's where we'll get value from. Because they've been pushing us to say, well, what does the health system really do? And we've been reflecting on some language that it seems like the purpose of it is to help people thrive, to prevent disease when possible, to cure when you can't prevent, to care when you can't cure, and all along to empathically partner with patients to end harm, improve their outcomes, and reduce waste. But we need those specifications.
So I would add, when we think about the world, at least in the legacy form, we see the provider system speaking the language of the EMR or EHR, and we see the payers speaking the language of claims. And both of these data sets, if you think about the cost-quality equation, actually need to come together.
Right.
And so I love the comment around, there are foundational investments that have been put in place to be able to get the clinical information all in one spot. But there are light touch solutions that can actually cross. And part of what, we all need to invest in is how do we actually bring that information together so we're making decisions on that cost quality continuum, not just on one axis or the other. And then there's also all the other parts you mentioned, social determinants. It's a big factor in how people respond to those choices. And so how do we continually bring new data? The challenge in the past is that that was extremely expensive to be able to bring everything together. And I would say we're still in a spot where we're not all willing to share that information. And with the new advent of new technologies around machine learning, AI, cloud-based computing, there are options to try to bring that together in a more cost-effective way than in the past. But there's still a challenge because people are still paying for their EMR implementations, right?
If I could just add one point, I want to underscore what Michael and Peter alluded to, and that is the time it takes for clinicians to catch up with their documentation. And one of the issues in healthcare right now is the issue of clinician burnout and satisfaction. And in fact, some of you may be familiar with the framing of the triple aim. Well, now we're talking about the quadruple aim. So it's not just patient experience, population, health, and cost, but also work-life satisfaction for our clinical workforce. And so I think it's really critical to think about that as we go forward in terms of solutions. Part of it is the issue of the technology burden, but there are other aspects. And I think it's still an open question, moving beyond the EMR, how technology can facilitate that in other ways, because we've been rooted in this sort of incentivized EMR strategy, and there are many other ways that technology could help us potentially.
So I'll just re-emphasize, my wife's a gastroenterologist, and she was on Lionel last night doing her charts, so I didn't get to see her. So I think this is a big issue for me personally, and I think for every physician around. Audrey, do we have a question from
Yeah, we have a
online?
question from the online audience. Where and when does this paradigm shift in consumer health literacy begin? At the time of first hospital admission or in high school? How early do you have to start?
As a pediatrician, I'd say really early. I have 16-year-old twins at home, and they're teaching me everything I need to know about technology. But to not make light of that, I think the issue of technology and data literacy starts very young. And we were talking earlier, waiting for this session to start, about sort of medical students today. I'm sure that we're seeing the same thing within other health professions, of the ease and understanding and literacy of interacting with data as part of their regular everyday. That is their life, whether it's Snapchat or Finsta, and it's reflected in how they interact with data in the clinical setting. I think the question is, how do we accelerate it for our existing cadre of clinicians? So because many of us are going to be working for many more years. And so I think those transitions will take some work. I'd be interested in what Kaiser feels is successful. I know you're building a new medical school to train docs differently, but how do you get your current workforce really interacting with technology more effectively?
So let me just, and I think the issue, health literacy is a huge problem as you want to partner with patients and get them engaged and managing their care. I do think it needs to start in elementary school, but it's a lifelong journey as medical technology changes, as things change, people need to learn more. I mean, I would point out a major problem, frankly, is language barriers. A large percentage of the population does not speak English. We rely on interpretive services. That's less than optimal. We've instituted a program of getting our fluent bilingual doctors better matched up with our limited English-speaking patients. So I think that's one approach as we talk about medical school. Recruiting diversity can help that, but I think we need to think more about language diversity as well as the other types of diversity, and that's going to continue to be a key barrier in terms of teaching physicians. It's actually hard because you get so used to the way you think. I do think it's a key part of education of health professionals, not just doctors, to really understand the magnitude of the problem. But starting with patients that may not even speak the language, there may be some technology solutions as translating equipment gets better, but I don't think we're anywhere near ready on that.
And I'll perhaps put out a provocative concept. And some of you may be familiar with this experiment called the marshmallow test, where it was shown that students who don't or delay gratification from eating the marshmallow have much healthier behaviors. They study longer, they do well in life. And when I think about health literacy and health behaviors, it is all about seeing the long term, Kurt, as you said, about delaying gratification. And there's mature training programs for that. But it's the same training programs that allow students to save, or all of us to save for retirement, to study and sit in your seat and get better grades. And I think our grade schools or preschools have an enormous opportunity to train on that asset, because it spills over into an economic benefit for our country, retirement benefit, and health benefits. And I don't think we've thought holistically about the importance of those life skills.
So the only thing I would add is I totally agree that we have to try to get that education earlier and earlier, but nothing prepares an individual for a cancer diagnosis. And so part of it, and I know I'm sure everyone on this panel is supportive of, when those health crises happen, the system has to invest in making sure that person has a navigator. It's not just up to the physician, because like you said, they may only be in front of their treating physician, or in complex cases, physicians, a small fraction of their overall day. So how do we invest in a navigator that actually helps them across all of the boundaries of the healthcare system, not just in navigating the clinical aspects with their provider team, but also in managing their diet when these changes happen and helping them understand how can they get to sleep. There's a lot of different challenges that come in, and some of that early education is great for prevention and healthy behaviors, but we still need to support people that have those acute problems that come up with a health crisis differently.
Great. Peter, you mentioned in your initial remarks about our quality measures. And, for those of you who don't know, we are healthcare is very regulated. Probably hundreds of measures come at us from accrediting agencies, from payers, from U.S. News and World Report and Leapfrog and other measures. And if we added them all up, Johns Hopkins Hospital literally has
About 1,200 or so.
1,200 measures that people want us to be measuring ourselves by at any one time. And I can't believe that all of them are important. So how do we get from where we are now to a system where we're actually measuring things that are going to improve the health and lives of our patients?
It's interesting that measurement developed perhaps works like a lot of politics, where every different agency advocates for my diabetes measure or this measure, or United has a set of measures that are different from Anthem, that are different from CMS, and they all get dumped on the healthcare delivery system, and we have no choice but to respond to all them, because we have reputation or financial at risk, and in some cases clinical risk. And I think we need to do a much more collaborative job, and this is a great role for the federal government to convene what are really meaningful measures for patients and for clinicians. Like your survival in colon cancer is a great example of doing that. And then making sure that the measures have some standards of accuracy. You would probably be surprised that there's no threshold for accuracy for how good or poor a measure needs to be before it is put in payment policy. And for decades, we've had this debate where policymakers say it's good enough, providers say, no, it's not good enough, and we've talked past each other. It's the most unscientific debate. We just recently published a paper a year ago that some safety measures that were used commonly in pay-for-performance, we did an evidence review, and not one of them made a basic validity threshold, and yet they were reported. We had to focus on them, and we had enormous amounts of money, and that is just squandering resources for a hospital, because all that work in measuring is not going to work in improving. And perhaps the most indicting area is we surveyed all of our department directors and physicians about what are they most worried about for quality and safety. And almost none of those 1,200 things came up on their list, right? And so now we have other things to work on, because that's really where the improvement is, and we can't ignore them. At the same time, we had to create an infrastructure to manage all these 1,200 measures, and we have no choice to. But if I were to say how many of them are really driving the needle, it's preciously few. And I think policymakers could change that by setting standards, perhaps crowdsourcing, or let patients and providers vote on how valid and reliable these measures are, so that we only focus on those ones that are most important instead of checking our box on 1,200 of them.
You know, I think we only have about 600 measures in Kaiser Permanente. I think we save a few because there's only one insurance company.
Very efficient
But
organization.
I think we need to separate measurement for accountability, which is really, for payment models, versus measurement for research and measurement for quality improvement, because the latter two are very different. And I think there it does help to have lots of robust measurements, so as you change your practice, you actually understand what it's doing and how it's impacting patients. And that's more measurement for quality improvement. When you talk about measurement for performance, I think one could even challenge whether paying people to improve quality actually has an impact at all, even if the measures were good. So I'm not a huge fan of it. I do think having some standardized measures helps people focus. So there's measurement on blood pressure control, and a lot of these are put together by the National Quality Forum or NCQA. I think that has helped generate some good movement on blood pressure control, and the CDC has been pushing that. It's not a perfect measure, and there's a lot of things wrong with it, and one could argue, but some of them are good enough, but we've gotten way too overboard, and in particular problematic is some of them are actually measuring things that may be harmful to care, and they eventually get removed, but not after they've done some damage. So when you have measurement for payment, need a very different standard than the other measurements.
Please.
So you mentioned policymakers' role in this, and certainly Medicare is critical in this space. But I want to mention another set of policymakers who are increasingly important as more and more patients are covered by Medicaid insurance. And so there we're talking about 50 different states. And while we've seen tremendous shift within Medicaid-covered populations towards managed care, the state is still making decisions about the accountability framework they use with their managed care plans, and then they decide what they're requiring their providers to report on. And there's variation there as well. And so I think we have to really bring all the folks who are sort of creating the demand for measures towards some more harmonization. Because yes, there may be a unique dimension of, for example, childhood obesity that you want to collect in Alabama that might be different from Vermont, but you'd have to talk to me about that. And so I think it's another important role is getting state Medicaid agencies and the managed care community together on this, because that adds to the craziness. It's not just 1,200 different measures, but sometimes it's 2 different measures for the same exact process of care, and it's measured differently, and that makes absolutely no sense.
Kurt, do you have-
Great point. I wanted to add something that I forgot, which is the concept that when a physician is seeing a patient, do we really want them thinking through, well, which insurance are they covered by, and whose measures does it apply? And if it's a Medicaid member, they get a different level of care than somebody else because the rules are different. That in itself creates not only waste, but I think creates equity issues. And I think huge philosophic issues with having multiple standards of care depending on insurance coverage.
Kurt, do you want to-
Well, I guess I'd like to be a little provocative, because I agree in terms of the administrative burden and the need to collaborate to sort of drive that burden down, right, to make sure that we can all focus on the consumer, on the patient. But then with this concept of more personalized medicine, do you all see the number of measures that you need to actually proliferate? And is it more of a technology and data solution to make the administration go away, or do you really see measures going down over time?
Yes. So that is a great question, and the hope of precision medicine, that is measuring in smaller subgroups of patients, offers enormous potential to give patients better care. So we're learning breast cancer is not one disease, it's 10 diseases, and each of those might need a separate treatment. But that far exceeds the brain power of clinicians to know how to map those treatments. So we will have to subsegment those groups into smaller populations and use technology to make sure they get better care. I see those precision measurements, though, in what Michael said on the research and the improvement side of measurement. I don't think they're going to be in payment policy. That's way too in the weeds. I think we might say, how are you doing for prostate cancer or breast cancer on a whole? And we manage that internally to make sure we're giving the right care to the right patients.
Yeah, and I think that's a challenge that we have to figure out how to solve, though, because if you're talking about smaller subpopulations and you're talking about trying to get the pharmaceutical companies to sort of really balance the pay-for-value equation, and if treatments aren't working, not have the same level of charge, it's kind of hard to avoid
Good
those
point,
things,
right.
right? So that's where we're trying to focus, is how do we actually reduce the administrative burden, but actually proliferate the number of measures that are available for the physician, and no one solved it yet, but it's coming.
Yeah, I do think measurement will go up. I was just last month or so reviewing our data on cystic fibrosis, and if you belong to the Cystic Fibrosis Association, there's, I don't know, I'm going to guess 50 or 100 measures in there, and it's great for improvement purposes, but for our system, it's based on around 150 patients, so you get into issues of statistical validity. If somebody were to start paying us based on that, there'd be all kinds of randomness. So as the size of the populations gets smaller, that's one of the constraints on these pay-for-performances. I would argue that if a drug is given to a patient and it's not working, I mean, one mechanism is the drug company bears the risk and somehow charges less or not at all. But, I mean, the other more obvious approach might be the doctor simply says, this isn't working, I've been monitoring the outcome, and I'm going to stop it. And I think we need to pull on both levers. Part of measuring will allow us to learn better what doesn't work, which is, I think, important.
I want to emphasize 2 points that are in this conversation, which is about measurement, but also the underlying clinical care, and that is complexity. The care we're providing is so complex, and we're trying to manage this sort of standardization move to make sure that you get the right care to the right patient at the right time, and then the heterogeneity, the variation within patient needs. And so, understanding not just what do we need to do better, which is about implementation, we really have to push harder on de-implementation. That waste that Peter alluded to. What do we need to stop doing that's really not contributing to the goals we share with our patients in terms of achieving the right care? And I do think while we develop more measures that are more granular, again, for research and improvement, even the ones we have are too much variation. We work on this project called the Registry of Patient Registries. So there's something like 1,300 registries, right? So that you get into it. This is sort of a database of, you get eligible if you've got X device or you've got X disease or you're this demographic. So there are all these different registries. And across them, they don't, measure diabetes the same way or atrial fibrillation. So even we're trying to harmonize the measures even within that tiny subset of this sort of data infrastructure. So I think there's progress to be made on rationalizing what we're currently doing and getting rid of stuff that doesn't work.
Great. So I'm going to ask one more controversial thing. And I know you don't represent your organizations, yada, yada, yada. But we woke up this morning and Graham Cassidy isn't going to get voted on. And we have a lot of staffers here. So if you had to advise people who are in this building on what one thing they can do to improve the health of this country and improve the value of care in this country, what would it be today? Lisa?
I've got a simple answer as these folks think about much more specific answers, which is get the best evidence and data to inform the decisions that you're going to be making. I think that is absolutely critical so that you understand not just the intended consequence, but also are thinking about the unintended consequences, and especially the variation of those consequences by community and state. I worked at the Department of Health and Human Services for 9 years, and it taught me a very good lesson on how big this country is and how diverse it is. And so, yes, it's our North Star, but evidence has got to be used more frequently and reliably. We talked about reliable care. Well, reliable use of evidence to inform policy decisions is also really critical.
So the piece that I would add, and I'll be brief, is continue to invest in not only the clinical aspects of improving care, but also tying it to innovative payment models. Being able to understand both sides of that equation are absolutely critical in driving that overall value component for everyone. And there were some statistics shared earlier on how much research is actually focused on new treatments or understanding disease, and making sure innovative platforms for how CMS can support payment is equally important to go after the other part of that equation.
I think a couple things. One is the government is a huge purchaser of health care. So, part of my job deals with other large purchasers, usually large commercial companies, but the government has the ability to simply say, I'm paying for this stuff, I want to see value, and drive patients and create policies that would either drive patients towards the better healthcare systems that provide the best value. So that, to me, is a straightforward one. I think that the concept of being evidence-based in the policies is key and sometimes forgotten, and I understand all of the politics, but trying to actually not only go by evidence, sometimes there is no evidence and you have to still make a decision, and I think there are ways that policies can be written such that we collect evidence as we go, and Medicare has done that in the past, where they've required, we'll cover this, but you better collect data and we'll assess the outcomes. I think that's another key thing. One thing not mentioned on policy has to do with payment, particularly for virtual care, and allowing more flexibility to have email, phone visits, video visits, those types of care covered in some kind of way with a reimbursement system that can reward that. I think it adds much more value, and other folks have talked about how patients may value that kind of care more.
And Dean Rothman, I perhaps will open with what I began with, is that build trusting relationships across the variety of stakeholders. That healthcare is so complex, and our history of health reform is we get it wrong much more often than we get it right. There's unintended consequences, and any one group is going to have a myopic view of the elephant. And I don't think we have enough structures to bring people together to be humble and curious about alternative views, so that we work together to pull on all these levers to move the U.S. where we want to go. The hopeful part is that I believe all these different stakeholders are aligned on what we want to do. We want high-value health care, whether it's the private sector, regulators, or payers. The challenge is I think we too often think I'm right and others are wrong, and leads to poor decisions. So I would encourage you to listen to those diverse viewpoints and work together to design a system that serves the people of this country.
Great. So I think we have about 10 minutes left. I'm going to ask each of you that, give you about 2 or 3 minutes to summarize what you've heard, and again, think about how we move forward in high-value care. Kurt, we'll begin with you, and we'll go down that way this time.
Great. So, again, I appreciate being part of this, and I appreciate being able to learn from my colleagues as much as contribute to the conversation. So, part of what I'm taking away is really that balance between driving clinical quality, which is really, really important part of the equation, as well as how do we innovate to drive the overall total cost of care, and not just the components of that total cost. and really the investment in research and innovation, not just in the treatments, but also in the ways that we engage with patients and providers, provide new visuals, new data, new analytics to try to influence behavior, and ultimately, continue to try to personalize what the goals for treatment are, what the cost people are willing to pay, and then drive that down to the individual consumer. So I think there's a lot of work left to do. This is not an easy equation to solve, but we're striving every day to help make the healthcare system work better for everyone, as I know everyone here is.
So I started with my 3 points around research, precision, and patience. And we've heard various dimensions of all three of those from this panel. And I want to add two in addition to those sort of core themes. One is the reality that evidence and innovation also coexist. And the pace of innovation in this country with the technological transformation, the payment changes, is really outpacing at times our research world's ability to sort of measure and rigorously evaluate. So I think there's work to be done in understanding how do we have new research models of federal government funding that allows us to work much more in partnership in timelines with delivery systems to actually then understand what is happening and what impact it's happening. Because there's an old adage that all improvement is change. Not all change is improvement. And that's the question we need to answer as we work with this innovation, with the data, and with our clinicians. The second point that I didn't mention in my opening remarks that I want to emphasize that's come up today is the role of payment. And this is both in the public and the private sector. We've really, it's complicated, okay? There's no easy solution for the payment models. But here again, innovation and rigorously evaluating the impact of different payment approaches is absolutely critical, because at its most fundamental, payment is not just about making providers or patients do the right thing, depending on what is covered or not. It's about getting out of the way and letting providers do what clinicians have been trained to do, what we all want to do, is achieve high-value care, whether we're a clinician or a patient. And so sometimes those payment models and the regulatory frameworks that they live within actually impede that professionalism and that desire to give the best possible care to our patients. So I think underscoring the opportunity with payment model innovation to really get to a better place. It's not going to be easy. All the money that's going into healthcare is paying somebody's salary, right? So there will be disruption, and we have to be mindful of that and be willing to do it, but all, I hope, in the goals of getting to a better place than where we are today.
A couple of comments. This has been a really fun panel, and I've enjoyed all of the comments, and I think they're all spot on. And just a couple things. We've talked about research a lot. I want to talk about the learning organization, which I think is key. Most of what physicians and other healthcare professionals do is not particularly evidence-based, and that's not a criticism of them. That's just a simple issue of the complexity of care and the difficulty in studying everything. So much of what's done is based on anecdote, experience, etc. As we have these EMRs that we've spent so much money on, we have the ability to collect data and learn from it, become a learning organization, and I think that's going to be one of the key transformational events. It's different than classic research, and it needs to be more rapid cycle, and I think there's a very blurry line between what's quality improvement and learning and quality versus research. And we need to create, I think, some policies that will facilitate the quality type learning. And the other thing related to that is people are offering up solutions for things. You see that particularly with technology. I think we need to spend more time actually defining the problem we're trying to solve very crisply rather than jumping to solutions prematurely. I think the EMR is a good example of that, where we put a cool tool in and didn't think through why are we putting it in and what problem are we solving. And I see that as going forward another big thing. So first define the problems before the solutions, creating a learning environment, And lastly, I want to emphasize culture and leadership, which I think needs to come from within the healthcare delivery professions themselves, and having things led by healthcare professionals with the right values and culture, I think, is also going to be key going forward.
A couple reflections. Building on something Lisa said earlier, it's important for all of you to know that much of the debate about health reform is only on the access piece. It's a critical thing, but it's not really driving value. There's some payment reform part of that, but the big issue with that is access. We should provide access. We have additional work to drive value. And I think the major thing that we need to do is get laserly focused on a common goal and realize we have to work collaboratively, each having a different role to drive that, but through at least a model or a framework that we see how it fits together. Lisa mentioned some of the national work on reducing infections. To put it in context, this type of infection killed more people than breast or prostate cancer. Enormous problem, and they're down by 85% across the U.S. And it happened by lazily focusing on a goal. When that work started, HHS measured these infections 5 different ways. And some said the problem's big, some said it's little, some said it's getting better, some said it's getting worse. Chaos. You couldn't move, and that's what we feel on a lot of these things. We galvanized around the CDC measure and aligned everybody to do your role, but focus on driving that measure nationally at many different levels, and it's what worked. And I think that's the kind of approach that we're going to need to drive value. Agree on what we're a measure of value, because we've talked about it. There's really not even any metrics of what we mean or how we know we achieved it. And then finally, for us to be humble enough to recognize that anything we do will have unintended consequences, because this is so complex, and trying to anticipate and be mindful of those. And one from my perspective is the great pressure on academic medical centers. The future of academic research and discovery, I feel, is really threatened, and we need to be mindful of that, because that's the engine for future growth and discovery. And so those are some 3 things: recognize its access, align around a purpose, and invite everyone to solve it, and be humble enough to say we will get some things wrong, and we have to be aware of them.
I just want to add one last thing, because one thing Peter said really struck me. I think collectively in healthcare, we actually have to do a better job of telling the story of our successes. I think the people that work in the field see that because they're engaged in it, but we don't necessarily actually do a good job. I think the general public at times thinks that we're okay with the status quo, right? And so telling those stories where there is an innovation, there was access, it did move the needle for clinical, and we were able to get to an affordable cost. And many have come up in this panel. But I don't think as an industry, overall in healthcare, we're really doing a good job telling the people of the United States that we are moving the needle in cases, and we're continuing to work on it every day.
So, Kurt, I couldn't have said it better. Again, having a little bit of the long view on this, and I see where we were 30 years ago, and I see where we are today, I really see many parts of our healthcare system focused on bringing value and improving the health of our patients at a lower cost, more so than I've seen ever. And again, I think many of you summarized how I would summarize what I heard today was that it's people like you up at this table with who I think are such great experts and had so many good ideas, bring you together, many parts of the system together with people who are driving the issue here, many of which are in the building that is above us, and collaboratively trying to come up with focused solutions to the issues that we're having, I actually think gives me great hope, because I think many of us are working tremendously hard in improving value. And if we could just get everyone together in the room and start to drive this, I think the success we're having would be accelerated. And I think a lot of people around the country would appreciate what I think should be the major thrust of everyone, which is to get value in our system and high value. And I wanted to just again reiterate, I thought this was a terrific discussion. And I learned a ton this morning. I hope people in the audience did too. So thanks everyone for your time on this panel. Some of you traveled all the way from California. Thank you. And thanks everyone for coming today. So we appreciate it.
Thank you.